Hey, Chrissy, thank you.
You're ready? Okay, good. And I am going to mute.
All right, well, we're going to go ahead and get started, everyone. My name is Jimmy Gale. I am the Capacity Building and Community Mobilization Manager for the Louisiana Department of Health STD HIV Hepatitis Program, or SHIP. Today, I was asked to come in and speak with you all about serving the LGBTQ plus community. And we really want to come at this from a trauma-informed lens and some best practices that could be implemented within your practices or clinics to better serve LGBTQ plus people within our state. Let's go to the next slide. Today, some of the things I want to cover, we only have 15 minutes, so we won't be able to solve any of the world's problems today, but give you some thought points that you can move forward on and consider. So today I want to talk about sexual orientation and gender identity. We're going to talk about trauma and why our approach to that matters. We're going to touch on health disparities within LGBTQ plus communities, and then also ending with how can I, as a provider, provide culturally appropriate care to my patients. Next slide, please. So the first important thing I want to talk about is sexual orientation and gender identity. This is something that oftentimes in clinical settings get blurred together or muddled up a bit, but they are two very different things. So what is sexual orientation versus what is gender identity? We're going to go on to our next slide. Many of you may have seen this graphic. It makes the rounds fairly regularly, but I think this is a helpful way for us to think. So as on the screen, you'll see our genderbread person. And there's also lots of little cute graphics added to that. So the first one we want to talk about is sexual orientation, and that is where the heart is. Your sexual orientation helps dictate who you are attracted to romantically, physically, or sexually. Very different from everything else. Sexual orientation and your gender identity are not one and the same thing. Oftentimes we think of them as that because we have added the T into LGBTQ as we support and uplift the experiences of people of trans experience. Biological sex is what your marker is at birth. The gender that is found within your body, natural DNA markers there, but your biological sex doesn't always line up with your gender identity or your gender expression. Your gender identity is what's in your head, how you think of yourself. I once had a friend who was a person of trans experience explain to me that when they dreamt the person that they saw in their dreams, that is how they wish to present in the world. So your gender identity may not always align with the sex that you were assigned at birth, and that's okay and perfectly normal. Your gender expression, however, is how you outwardly present your gender. Oftentimes we have questions coming up because we're hearing more discussions about folks that are non-binary, folks that are using terms and pronouns that are unfamiliar to us. Your gender expression can have nothing to do with anything else on this screen. It's what makes you feel good, makes you feel most like yourself, and how the rest of the world gets to see and experience you. So your sexual orientation is really depending on who you're attracted to. And that has not, like I said, nothing to do with your gender assigned at birth or your current gender identity. It's who you're attracted to. And there's no picking and choosing that. It's just how things go. And as the world has moved into a more digital age where folks are more connected more than ever using social media and the internet, we oftentimes hear folks saying, well, back in my day, we only had this. The reality is all of these sexual orientations and gender identities have always existed, but now we have a global network of people that are helping find others like themselves and provide support and resources and find the language to really put into words who they are, how they feel, and how they wish to navigate all of these spaces. We're going to go on to our next slide. The next thing I want to touch on today is pronoun usage. This is a hot button issue for a lot of folks, specifically within healthcare settings, because they don't necessarily understand. Pronouns have always been a part of our vocabulary. We use them without thinking about it. We use them without any thought at all. They're just a part of how we speak to each other and how we identify others. Personal pronouns are an important part of this conversation. Oftentimes we will hear on registration and intake paperwork the phrase preferred pronouns. We're stepping away from that because it's not a preference, it is who these people are. Myself, I use he, him pronouns. I was assigned male at birth. I'm very comfortable in my skin, So I'm sticking with he and him pronouns, but I accept anything used with respect. For transgender or gender nonconforming clients, it's important to use the appropriate pronouns and names as a sign of respect and collaboration. Oftentimes, we will have clients come into a clinical setting and have the receptionist at the front desk, when asking for their date of birth, use their former name or their dead name, the name that they do not go by, that they do not answer to, that does not reflect who they are now, today. So by respecting those pronouns, by utilizing the names provided to you by your client, you're creating a space where people are going to feel more comfortable. On the right-hand side of the screen, you'll see some words in red. Misgendering is a common practice. And I'm also aware of the fact that oftentimes in your electronic healthcare records, there's not a lot of options to include gender markers or pronouns. But when people come in that do not identify as the gender they were assigned at birth, it's important to make these notes and make a conscious effort to utilize those gender markers and pronouns effectively. If you've ever been into a space and somebody is using the wrong name or using the wrong pronouns for you, it can oftentimes just stop the conversation right there. And LGBTQ folks in general have a high level of mistrust within, clinical settings, within societal or institutional organizations. So being disrespected at that first step and at any stage along their healthcare timeline can halt the conversation and grow into more medical mistrust and them not feeling comfortable with you or your staff to have important conversations regarding their health and their wellness. As I mentioned before, dead naming is a big no-no. I don't know how many of you are actively working with transgender or gender nonconforming clients, but making a note in their medical chart what name they wish to be called is a really important step that we need to take. Let's say, for example, you accidentally use the wrong pronouns or you accidentally dead name a client. It is how you respond next that's important. If the client stops you and says, "I'm sorry, I use she, her pronouns, and my name is this," that is them acknowledging you and encouraging you to do better. If you refuse to adapt and to change in that setting, the conversation might as well be over. We're going to go on to our next slide. So trauma. Earlier today during your case conference, you were talking about how stress sticks with the body. We know that the body keeps score. We know the longstanding impacts of stress and of trauma. We see it here in New Orleans, for folks that are born generations post-Katrina. We're seeing PTSD in infants and children that weren't around for the Hurricane Katrina. These things have a lasting impact. And within queer spaces, it is important for us to really start with the conversation around trauma, because trauma can lead to a poor self-image. It can lead to low self-esteem, which could lead to staying in unhealthy or violent relationships. It can lead to depression and suicidal thoughts. And we already know that LGBTQ youth and people of trans experience are at a higher risk for depression and suicide. It can lead to substance use, whether that is drinking, smoking, using any form of illicit drugs, whether prescribed or not prescribed. It can lead to unhealthy lifestyle choices and risk factors in behavior, such as seeking out survival sex, making sexual health decisions that are not in your best interest. But all of these can be the result of a traumatic experience if clients are not set up with supportive services that are affirming to their identity and their sexual orientation. You are all in a position where you can start changing those conversations and setting folks up with resources that will help them thrive. A trauma-informed approach in your clinical settings can truly save lives and prevent further health disparities. Let's go on to our next slide. Up on the screen, you're going to see a graphic from the National LGBTQIA+ Health Education Center. I'm just including this to talk about the different levels of trauma. We have individual trauma, things that you have done, experienced yourself. Interpersonal trauma are interactions that you've had with other people, whether you have been bullied or beaten or abused by somebody else, whether they're family, friends, a community member, or a stranger on the street. Those situations stick with you. Institutional trauma is a big one that we see in a clinical setting where folks are not being respected. They're being spoken down to. They're not having a great healthcare experience. And societal trauma. I don't know if you all have been paying attention to the news over the last several years, but oftentimes LGBTQ plus folks are vilified in the media. And for young LGBTQ folks that are seeing this, the impact that it's going to have on their self-worth, on their self-image, and how they see themselves fitting into the bigger picture, that can lead to additional trauma for them as well. Next slide, please. So for health disparities, and that is the big point of today, um, members of the queer community can oftentimes experience various disparities at a higher rate than our straight or heterosexual peers. As I mentioned before, transgender and LGBTQ youth experience these at a much higher rate than those of other gay, lesbian, bisexual folks, and an even higher rate than heterosexual peers. So some of these health disparities that we see most commonly are increased rates of HIV and STIs. We see smoking is a very common health disparity, substance use, whether that's drinking, alcohol, using drugs, partying, all of those, depression and suicide, and homelessness. And I include homelessness in this list specifically when we're talking about transgender and queer youth. The studies have shown repeatedly that the rates of homelessness amongst these populations are much higher than heterosexual teens and young people, oftentimes because of rejection from their families, and rejections from their religious organizations, rejections from their communities, and they have no place else to go. So these are some of the most common. It's not the entire list, but these are the ones that we are focusing on within the STD HIV hepatitis program, within the various smoking cessation programs, and also just community support initiatives that are being supported across the state. Next slide, please. Since I do work for the STD HIV hepatitis program, I would be remiss if I did not include some data for you all here. As you can see on the screen, this is our most recent data that we have regarding HIV diagnoses within the state of Louisiana. On the right-hand side of the screen, you will see a map highlighting, a lot of our rural parts of Louisiana. We tend to see more of our diagnoses clustered in regions 1 and 2 around New Orleans and Baton Rouge, but that does not mean we're not seeing it in other places. Affected subpopulations, our number one impacted population are gay, Black, or bisexual men. And it's important for us to make sure that we are including this in the conversation. We know that racial disparities coexist and intersect with LGBTQ disparities. We want to make sure we're highlighting that. But I also wanted to include this that coming in second in terms of our most highly impacted community, it's not LGBT, it is women of color that we're seeing the second highest spike in new diagnoses here in our state. But on this graph, we see Black gay and bisexual men, white gay and bisexual men, Hispanic gay and bisexual men, and further down on the list, gay and bisexual men who also inject drugs. We can move on to our next slide. So as you may be aware, Louisiana currently ranks in the top 10 for all STIs as well as HIV. Shame and stigma play a giant role in furthering this health disparity, leading folks to not get tested and seeking out treatment. Oftentimes, when we are talking about rural Louisiana, there's not as many healthcare options for folks, whether it's a community clinic, a parish health unit, and these are small communities that are close-knit, and often folks are avoiding seeking out care because they don't want to run into somebody that knows them, because they're afraid. They don't want to be identified as going to that clinic, seeing that doctor. Stigma and fear is a big part of it. Making sure that we are providing staffing in these spaces that is reflective of the communities that you're serving. When a LGBTQ person comes into your waiting room, is your receptionist going to be open and affirming and welcoming to people that may be different than them? We are a very religious state. And that's a wonderful thing for Louisiana. But oftentimes, many LGBTQ folks, not all, have a difficult relationship with organized religion for the way that they have been treated and stigmatized and rejected. So some things I wanted to ask you all today. Are you asking the right questions at intake? I touched on earlier sexual orientation, gender identity. Those are key markers that we want to be collecting to make sure that we are providing the best service possible. Are your patients comfortable discussing their sexual history with you? Have you cultivated an environment and a relationship with your patient where they feel that they can tell you about who they are, who they're attracted to, and who they're being sexually active with? Are your patients even comfortable disclosing who they are in your clinic? If they're coming into your waiting room and they're seeing Fox News on the TV or there's gospel or religious music playing in the background, are they going to think this is a space where they can be their authentic self and seek out the services that they need? And lastly, are you running the right tests? Because shame and stigma is a big part of this conversation, we will oftentimes have folks come in to seek out testing services. And when asked the question about their sexual orientation, they will 100% of the time identify as heterosexual. But if we're asking the questions about the type of sex that they're having and with whom, the responses might surprise you. There are a lot of folks that identify on paper and in a clinical setting as a heterosexual man, but in reality, they are engaging in sexual contact with other men. So, are we creating an environment where folks can be open and honest and vulnerable with you as a provider, as a medical health professional? And if they're not, your chances are we're not giving them all the right tests, all of the right referrals, and all of the services that they need. Next slide, please. So, some best practices. Intake paperwork. If you're not doing so already, please include questions about sexual orientation, gender identity, and sex assigned at birth. Many of you already are. It's built into a lot of the electronic health record systems. Some of you may still be using paper charts, which I miss personally. I love a paper chart. I love doing chart notes on paper. But it's important for us to collect this information. Nationally and globally, we don't have a lot of data on transgender individuals, people of trans experience, people that are gender nonconforming. So by asking gender identity, asking sex assigned at birth, it could help us provide more data and improve services further for all Louisianans. For sexual health history, as I mentioned a moment ago, ask about the types of sex people are having, with who, and what kind to ensure that you're running the appropriate tests. If somebody's coming in for their annual sexual health screening and you don't know that they're currently having sex with multiple genders, multiple partners, both insertive or penetrative partners, you may not be doing the right swabs, the right urine samples, the right questions. So making sure that sexual health history is a part of that conversation. I know it's a difficult one, and many of you may be working within faith-based health institutions where these conversations are not common. But finding a way to do that and seeking out more education and training and support is always a great option. Here at the STD HIV Hepatitis program, we do have providers on call to help answer these questions and help you troubleshoot. And I myself am also a resource as well. And my contact information will be on the last slide for you. Respect and confidentiality. As I mentioned before, a lot of rural areas, people are avoiding clinical settings because of sensitive issues, because they don't want to be seen and they don't want to be recognized. Everybody talks in a small town. We know that. Mirroring language. And this is an important one that is very difficult for a lot of folks that have been doing this work for a long time. If one of your clients is coming into the clinic, coming in for an appointment, and they use a term or a phrase that you are unfamiliar with, it's important to pause and ask questions. And whenever appropriate, use this language when discussing their health needs. My background has been in sexual health for 15 years. I remember working in a clinic on the West Coast that primarily focused on the sexual health and wellness of gay and bisexual and transgender men. And oftentimes I'd be in the exam room collecting swabs and taking a history, and they would use a word or talk about a genital or body part in a way that I had never heard it described. Sometimes when they gave me a definition, I don't know if I'm comfortable saying that in an exam room, but being flexible and using language that they identify with and that they are comfortable with is a sign of respect and collaboration. And lastly on the list is representation. It's important for us to have include people in your settings, in your spaces that reflect the communities you're serving. And having LGBTQ people on staff, having people living with HIV on staff, having a diverse, colorful, and robust staff is a benefit to everyone. For folks that are hesitant to come into your space and may not feel comfortable, whether it's medical mistrust or shame, fear, or stigma, walking in and seeing people that look like them, that act like them, is a great way to open that door and open that space and let them know that they're welcome here. If this clinic hires an openly queer person to work their front desk, maybe I am okay to be in this space. And so making that a constant lens you're looking through when you're hiring, when you're onboarding staff, hire people from the communities that you're serving and let them know that they are welcome, wanted, and celebrated in your space. Next slide, please. And that's the end. So here's my contact information on the screen. Feel free to email me anytime a question comes up, whether it's about paperwork or best practices, or how do I actively and appropriately link someone into HIV services and care? Am I running the right tests? I'm happy to be a resource for you at any time that you need it. Please reach out. Do not hesitate. And we look forward to working with you and collaborating from the STD HIV hepatitis program.